Hello, I'm Cheryl Zimmerman from the University of North Carolina, Chapel Hill. This presentation is a short overview of North Carolina's Adult Care Home Accreditation Pilot Program, a statewide program to improve care and outcomes in assisted living. The project is endorsed by the North Carolina Senior Living Association, the North Carolina Assisted Living Association, and other organizations. The evaluation is being conducted by the University of North Carolina, Chapel Hill. The project is funded by the state of North Carolina, and accreditation is provided by the Accreditation Commission for Healthcare. Before I overview the evaluation, it'd be helpful to provide a brief history of the program, for which I turn to Francis Messer, President and CEO of the North Carolina Assisted Living Association, and Jeff Horton, Executive Director of the North Carolina Senior Living Association. After which, Teresa Hoosier from the Accreditation Commission for Healthcare will overview accreditation.
Hello, my name is Francis Messer, and I'm the President and CEO of the North Carolina Assisted Living Association. As many of you may be aware, assisted living care and outcomes of that care have become much more challenging due to a number of factors. There has been a significant growth within our industry. Not only has assisted living become significantly more diverse, but resident acuity is much higher and more complex than in previous eras. Additionally, assisted living has always struggled with staffing challenges, which have become more overwhelming and pervasive post-pandemic. Due to all of these factors, we know that care quality is harder to assure. We also know that the current regulatory process has many limitations. It is not focused on outcomes, but on compliance with minimal standards. It is inconsistent since different county DSS monitors and state survey teams conduct inspections in different ways and with different perspectives. It doesn't allow for technical assistance regarding how to improve care or address problem areas that providers may face. The good news is accreditation alleviates some of these limitations because it is focused more on standards that promote quality of care and positive resident outcomes, and is very common in the healthcare arena. It is a tried and true process that has been used effectively for decades with hospitals, ambulatory, surgery, home health, hospices, and behavioral health.
Hi, my name is Jeff Horton. I'm with the North Carolina Senior Living Association. The history of the pilot program is that North Carolina Senior Living Association and the North Carolina Assisted Living Association have been promoting quality improvement for years, and we believe accreditation is a promising strategy for North Carolina's adult care homes. Working with the legislature, we were able to secure funding for a 2-year pilot program to begin this year. The goal of the program is to determine if accreditation for adult care homes results in better outcomes for residents. The methods will involve interested providers being randomly assigned to an accreditation or comparison group and provide information on care and outcomes. We're hopeful that the results of the accreditation pilot program can inform changes to the licensure process and requirements. Specifically, what is currently being done in North Carolina and also across the nation is accredited providers many times, once they achieve accreditation, are typically not routinely inspected or surveyed by their state agencies. We're hopeful this could be used for North Carolina's adult care homes if the results of the accreditation pilot program are positive.
Hello, I'm Teresa Hoosier, Program Director for Accreditation Commission for Healthcare, or better known as ACHC. Today, I want to provide a brief introduction of what accreditation is and how it's beneficial to organizations. The best definition or summary of accreditation is a high-level and effective quality assurance and performance improvement review. This involves a deep dive into an organization that will provide a multitude of benefits. Some of those benefits are recognizing the organization's strength, highlighting those, and then identifying areas of improvement. By using a collaborative approach to survey, this allows the organization to find ways to enhance education and promote overall compliance throughout. Accreditation indicates the organization meets and often exceeds a defined standard of care. And then most importantly, it demonstrates a commitment to the community for the delivery of quality care. Accreditation is widely used across the nation for hospitals, home health, hospice, and other clinical settings. With this accreditation, ACHC will assign a dedicated account advisor to the organization. That is your point person or your go-to person who will help organizations throughout the process. Survey is typically 2 to 3 days in length. Surveyors will share observations with the organizations throughout the entire survey. Again, identifying strengths and recognizing those, and then also identifying weaknesses as to where an organization may need improvement. And then finally, accreditation is awarded for a 3-year term or 36 months. So post-survey for an organization, the accreditation, once it's approved, an organization will receive a certificate with their accreditation dates.
With that overview, I'll explain how the statewide evaluation is being conducted. Research staff from the University of North Carolina at Chapel Hill contact randomly selected assisted living communities in the summer of 2022, and up to 150 are randomized to either the accreditation group or the comparison group. Those randomized to the accreditation group are referred to the Accreditation Commission for Healthcare, and their participation is free, which is more than a $13,000 value. Those randomized to the comparison group are offered reduced fees for accreditation at a later date. I can't stress strongly enough that randomization and broad representation are critical. The state requires that this be a rigorous evaluation, which means that the entire range of assisted living communities from across the entire state must participate. That's the only way to achieve a truly valid evaluation of accreditation. If only resource-poor communities participated, change might be more challenging. And if only resource-rich communities participated, there might be little room for improvement. For the evaluation, which I'll describe in the following slides, information from accreditation and comparison communities are submitted quarterly for 2 years. Because it takes time and effort to compile the information, all communities are reimbursed $500 per quarter, meaning $4,000 over the 2 years. And the UNC research team, the North Carolina Senior Living Association, and the North Carolina Assisted Living Association are available throughout the project to provide help to compile and submit the information. All of the information provided is completely confidential. The information from all communities will be combined, and it never will be identified with a specific community. We've worked to make the evaluation as straightforward as possible. UNC emails a personalized instruction manual to each community containing the evaluation forms, explaining how to obtain and submit the information, and including contact information if questions arise. Each community can provide the information to UNC in the way that suits them best, online, fax, or postal mail. And as I mentioned earlier, UNC and the associations are available to provide support at any time. The comprehensive evaluation includes 4 types of information compiled by the assisted living community. This slide lists all 4. I'll detail them in the following 4 slides. First, there are 3 types of questionnaires, one completed by the administrator, one by a small number of residents and families, and one by staff. Second, the community reviews their staffing records. Third, the community reviews resident charts. And fourth, the community observes medication administration for a small number of residents. I'll present a slide for each of these 4 types. The administrator completes a questionnaire once at the beginning of the project to describe the community, with the sample question being, do you have a registered nurse available on site? Twice a year, 15 randomly selected residents or a family member, if the resident isn't able, completes a questionnaire to describe satisfaction, well-being, and care, with the sample question being, how do you rate the care you receive? And similarly, twice a year, nursing and direct care staff complete a very short questionnaire regarding their satisfaction and burnout, with the sample question being, how satisfied are you with the recognition you get? Next is a review of staffing records, for which the community reviews its own records twice a year. Consistent assignment asks the number of direct care workers for each resident on a specified week. Turnover asks the number of staff employed and retained. And staffing levels ask the number of hours worked within staff categories on a specified day. In terms of resident information, the community reviews resident charts and records quarterly, specifically about the number of residents in 6 areas: advanced care planning discussions for new residents, falls with injury, emergency department visits, hospitalizations, rehospitalizations, and discharge due to behaviors. And the last type of information is the community's observation of medication administration for 5 randomly selected residents each quarter. This is the summary sheet that's completed. The rows summarize whether the resident's identity was confirmed, how many medications were observed, how many inaccuracies were circled on the actual observation form, such as related to the wrong medication being administered, whether a medication was not administered, and whether there was a significant medication error as defined on the observation form. So that's it. The evaluation gathers 4 types of information: resident medications and information quarterly, and staff records and questionnaires twice a year. To more clearly summarize the material, this slide lists the items from the questionnaires, chart reviews, medication observation, and staffing records. Looking at the items compiled this way, it's clear that these are important outcomes and every one is relevant to the well-being of residents and staff. It's also worth mentioning that the measures that are being used to record the items were carefully chosen. They're either similar to those used in nursing homes or endorsed by organizations such as the National Center for Assisted Living or the National Quality Forum, or are of research quality, meaning that they're valid and reliable measures of care and outcomes. I'll wrap up this presentation with 3 slides of frequently asked questions. The first is about the evaluation itself. Can communities use existing electronic records? The answer is yes, absolutely, if the items and time period map to the evaluation. But even then, it may be necessary to review additional records, such as if a resident who fell actually had an injury. What if a community has questions or will be late providing information? For this, the UNC team is available to help, and their contact information is readily available in the personalized manual. How does a community receive payment for providing information? UNC or the associations will contact the community as soon as it's randomized and will arrange for payment. Some questions are about accreditation, specifically about its focus. Accreditation focuses on 7 areas, including program and service operations, fiscal management, and other areas. If the community is in the accreditation group, staff from the Accreditation Commission for Healthcare will contact them to provide details and begin the process. The question has also been raised whether a community in the comparison group can independently register for accreditation, for which the answer is no during the time the project is being conducted. To be in the evaluation, communities must agree to be in the group to which they're randomized, but they can register for accreditation at a reduced fee after the project is completed. And the last questions are about feedback, one being whether communities in the accreditation group can share what they're learning with communities in the control group. The answer to this is no, because to have a valid evaluation of the benefits of accreditation, it's important to not share information during the 2-year project. Not sharing information is especially stressed for communities that are affiliated with each other. But on the upside, while the project is being conducted, some reports and findings may be shared by the UNC team, and all information will be shared at the end of the project. Finally, why a 2-year evaluation? The answer to this is straightforward. It takes time to change care and outcomes. Thank you for listening to this presentation. If you have questions, feel free to contact Jeff Horton, Francis Messer, Teresa Hoosier, or me, Cheryl Zimmerman. Or visit our website, North Carolina Assisted Living Project.